Hi, good afternoon to all. Today I will be taking a new topic from recent advances hematology, that is allogenic hematopoietic stem cell transplantation. So, bone marrow transplantation or hematopoietic stem cell transplantation is a life-saving procedure for many malignant as well as non-malignant hematological diseases. This procedure has many technical variations that is based on primary disease, the patient's age, and where the available facilities are there to do the bone marrow transplantation and how much the center has experience. So, what is hematopoietic stem cell transplantation? It is intravenous infusion of hematopoietic stem cells that are derived either from bone marrow, peripheral blood, or the umbilical cord blood with the goal of re-establishing normal blood cell production and immune function in patients whose bone marrow or immune system is damaged or defective due to disease, chemotherapy, or radiation. Okay, so from the definition itself, you can understand it is an IV infusion of hematopoietic stem cells, that is, hematopoietic precursors that can proliferate into mature blood cells. And these are derived from three sources, that is, bone marrow, peripheral blood, or umbilical cord blood. And the goal is to re-establish the normal blood cell production and the immune function, because in the blood cells WBC is like T cells and B cells are for immune function. So as you reconstitute the blood cell, the immune function is also restored. So, and these are used in people or patients whose bone marrow or immune system is damaged, okay, due to disease, that is leukemia, lymphoma, plastic anemia, etc., or due to chemotherapy or radiation. Also, these hematopoietic precursors and the cells have been reduced. That time also you will give stem cell transplantation to reconstitute the blood cells. And it is a medical procedure in which a patient receives hematopoietic stem cells to replace the damaged or destroyed bone marrow. That is, in short, what you will call what is hematopoietic stem cell transplantation. Now, there are three types of hematopoietic stem cell transplantation. First one is autologous, in which patients' own stem cells are used. Okay, suppose the patient is having lymphoma, in which lymphoma is, as it is a localized disease in the starting. So if it has not spread to the bone marrow or the peripheral blood, you can take the patient's own peripheral blood or bone marrow in which there is hematopoietic stem cells and use to treat the lymphoma targetedly where it is not being responding to any other kind of treatments. Okay, so that is autologous transplant. Lymphoma is just an example, it can be used for other diseases also. Allogenic transplant is where stem cells come from a genetically matched donor, that is not from the same patient. It can be a related donor, that is HLA matched sibling like brother, sister, mother, or relative, or maybe unrelated donor also. And then what is syngenic transplant is stem cells come from an identical twin, then it is called syngenic transplant. Indications of transplantation are many, like in malignant disorders, it can be AML, acute myeloid leukemia, acute lymphoblastic leukemia, and in chronic leukemias, myeloid and lymphoblastic types, multiple myeloma, myelodysplastic syndromes, and lymphomas. And non-malignant disorders, mainly thalassemia major in India and aplastic anemia in India, then Fanconi's anemia, sickle cell anemia, immune deficiency disorders, and paroxysmal nocturnal hemoglobinuria. So, what are the treatment goals? Is that mainly it is to replace the abnormal cells by the healthy donor cells. Okay, and then other effects are to rescue the patient from myelotoxic effect of anti-cancer therapy. After chemo and radiation therapy, the blood cells decrease like anything. Okay, because it is chemotherapy, the cells are affected. Okay, so now to reconstitute the blood cells, you start giving stem cell transplantation in patients in which colony stimulating factors are not effective. Okay, and then it also have a graft versus cancer effect. Okay, which is also very important. Graft versus cancer effect is when we are giving stem cell transplantation along with the donor stem cells, there can be donor lymphocytes in the same bone marrow or peripheral blood sample. So these lymphocytes, especially T lymphocytes that are present in the donor sample, can as act on the cancer in the patient, that is the host. Okay, so the donor peripheral blood or bone marrow can have T lymphocytes that can act on the cancer of the patient, and it can go and destroy the cancer cells as well. So it is called graft versus cancer effect. Okay, and it is more for peripheral blood transplants because mature lymphocytes are more in peripheral blood as compared to bone marrow. And the stem cell sources, as I said, is three types. That is bone marrow, peripheral blood, and cord blood. Bone marrow, it is harvested from the posterior iliac crests under the spinal anesthesia or general anesthesia, and the sample is collected in a bag with the anticoagulant. And the traditional source has balanced cell composition, that is with myeloid, megakaryocyte, and erythroid precursors. And other two sources are peripheral blood and cord blood. And among all the three sources, the richest stem cell source is peripheral blood, which has 0.1% stem cells. Okay. And then uh, the peripheral blood is collected after giving granulocyte colony stimulating factor or granulocyte monocyte colony stimulating factor for 4 to 5 days so that it can increase the amount of stem cells. Okay, you might be thinking bone marrow is having so many precursors like blasts and immature cells. Then why not bone marrow has more stem cells than peripheral blood cells? Okay, blasts are there, but blasts are also mature population. They are lineage specific. Okay, so stem cells comes even before that. Okay, even before the stage of blasts. Okay, so in number, peripheral blood has stem cells. That is more than even the bone marrow. And the sample we are collecting, bone marrow sample you get is little difficult and it is little less compared to the peripheral blood which is abundantly present in a patient which can be easily taken also. So stem cell source is richest in the peripheral blood. And along with that, it contains many mature lymphocytes also, as I said. So the graft versus cancer effect is more for peripheral blood. But at the same time, it has increased incidence and severity of chronic graft versus host disease. Okay. Graft versus host disease is when the graft, that is the donor's lymphocytes or immune cells, attack the patient's own cells, okay, host cells, which are not cancer also. So when the patient's non-cancerous cells are attacked by the donor cells because it will have the donor lymphocytes, there is a graft versus cancer effect as well as graft versus host disease also. So peripheral blood, because it has maximum lymphocytes, it can cause graft versus cancer effect, and it can also cause chronic graft versus host disease also. But after overall, the fastest engraftment is also for the peripheral blood because of its richest stem cell source. Then umbilical cord blood, it is easiest source to attain because placental blood it is collected from. And if you in medical practice you have seen so many placentas are taken from the labor room and they are simply discarded. So if you take the cord blood, you can process it and use it as stem cell source for the many malignant and non-malignant disorders. And then they have immunologically naive cells. So the graft versus host disease risk is very less because mature lymphocytes are less, and those cells in the cord blood are mostly naive cells. And they have the poorest stem cell source. Okay. You don't think that cord blood is like baby's blood, so it should have more stem cell source. The number of stem cells is different for the different sources. Okay. and according to the amount or the per millimeter cube of the blood present, the stem cell source differs in the stem cell numbers. So that is why peripheral blood has richest stem cell source, bone marrow the second, and then cord blood the least stem cell source. Now coming to donor selection, identical twins are the perfect match, obviously, but they are rare to be given. You know ki how many identicals are twins are there among ourselves itself. So HLA identical sibling, if you have a brother and sister who has same HLA, you need 6 by 6 match that covers HLA A, B and DR loci. You understand this in such a way ki see three loci are being tested, so 3 into 2, that is 6 by 6 match is required. And if you're doing testing for unrelated donor, you will add HLA-C and HLA-DQ loci also. So 3 plus 2, that is 5 loci. So you need 10 by 10 match ideally for matched unrelated donor. And why you need the HLA matching is to decrease the graft versus host disease or the graft rejection. Because if the matching is less, the patient's cells or the donor cell might show immune reaction and cause rejection more or graft versus host disease more. If you are using cord blood, the match can be even 4 by 6. Okay, is acceptable because they are immunologically naive cells. So there is low graft versus host disease. So what is immunologically naive cells? You know, when a person is maturing, there is central tolerance and peripheral tolerance. Okay, the T cells which are coming from thymus or bone marrow, they go and mature in the thymus and then in the bone marrow to become mature B cells and mature T cells. That is why you have T and B from thymus from bone marrow. Okay, so before maturation, the cells that are present, they are in the cord blood. So these cord blood cells are mostly non-matured cells. So if they are non-matured, they are not identifying any antigens as target or they are not going to produce any antigen antibody reaction. So they have least immunologically immune reaction producing cells. That is why it is called immunologically naive cells in cord blood. So graft versus host disease is least. So 4 by 6 match is also acceptable. So according to the registry of the bone marrow, over 13 million unrelated bone marrow donors are registered worldwide. Okay. But in that also Caucasians are mostly represented. Other races like Asian and African, still the level of uh, what to tell level of it is not the information is not as popular as it is in the Western countries. So we ourselves also, you know, we don't go to the bone marrow registry and we test our HLA and register in the bone marrow registry so that if someone needs our bone marrow, we can give it also. So that is more famous and more widely spread in Caucasian. So they have so much of unrelated donors, but still in Asia and in Africa, the unrelated bone marrow registry is still less. And now we come to conditioning regimens. Conditioning regimens are done before the bone marrow procedure is actually done. To the patient, you do conditioning, that is myeloablative conditioning or non-myeloablative conditioning. Myelo is something related to bone marrow. Ablation is that you are destroying it fully. So myeloablative condition is you are destroying the whole bone marrow of the patient, and it is done using high dose chemotherapy or radiotherapy that completely destroys the bone marrow function. Okay, and it will eradicate the malignant cells first of all if with whatever is present in the bone marrow, and as well as it suppresses the host immune system to accept the stem cells. And then it creates space also for donor cells. So if you're not giving conditioning therapy, already there are so many bone marrow cells filled. Bone marrow is filled with bone marrow cells. So you cannot give stem cells there. So it creates space, it suppresses the immune system of the host, it eradicates the malignancy, And as well as other thing is that it causes high organ toxicity. Okay, not other than the organ that is bone marrow, which is to be ablated, other organs like liver, GIT, skin, etc. also can be affected by the conditioning therapy, that is high dose chemotherapy and radiotherapy. Now, non-myeloablative conditioning is the recent development, that is reduced intensity conditioning. You are giving chemotherapy and radiotherapy in lower doses, only enough to suppress the immunity of the patient so that it accepts the stem cell transplantation and it doesn't produce an immune response against it. But still, it has some amount of blood cells so that it is not totally deprived of the blood cells of the patient. It can fight some of the infections, etc. Patient is not totally immunodeficient in this condition. So you're not destroying the bone marrow fully. And it also relies on the graft versus tumor effect. Okay. So when reduced intensity conditioning is there, you will use mainly peripheral blood source of stem cells. So there is T lymphocytes so much. So if there is residual malignancy present after giving lower doses, there might be residual malignancy or residual immature cells. So those cells are destroyed by the T lymphocytes that come from the donor transplantation. Okay, that is called graft versus tumor effect. And lower regimen or lower chemo or radio will cause lower organ toxicity, and it is especially useful for older patients. And it is effective especially in slow growing cancers like CML and CML, because there the process is very less, very slow. So you can gradually have the graft versus tumor effect and gradual conditioning, and there is time for the treatment to affect, because in acute diseases the disease is progressing so fastly. For reduced intensity conditioning, maybe the disease also will spread so much that stem cell transplantation may not be effective. So reduced intensity conditioning is used mainly in CML, that also especially in the chronic phase. So how is the bone marrow transplantation process done? So firstly, the stem cell is collected from the donor. So it is collected by bone marrow aspiration or peripheral blood collection. Cord blood is done from the placenta. And the total neutrophilic count required, sorry, not neutrophilic count, total nucleated cell, okay, or the bone marrow cells, the total nucleated cells required for successful engraftment is 1 is to 3 into 10 raised to 8 per kg of recipient's weight. Okay, this is 10 raised to 8. So total nucleated cells means bone marrow or peripheral blood, whatever cells are there with nucleus. Okay, you can estimate that 1 to 3 into 10 raised to 8 total nucleated cells should be there in the sample, and which is according to per kg of the recipient's weight. Okay, you are counting only total nucleated cells. We cannot differentiate how much is the stem cells present or how much is the immature cells or the mature cells present. That is why especially peripheral blood has stem cell sources more, because it has 0.1 percentage. In bone marrow also or peripheral blood, you know there is nucleated cells, but you cannot distinguish which is stem cells so much. So we just take a count of total nucleated cells. And then patient preparation conditioning regimen, as I said, myeloablative or the reduced intensity conditioning is done to destroy the diseased cells as well as suppress the patient's immune system. And then the stem cell is infused, and it is infused mainly through the intravenous route. The donor marrow cells, okay, will home into the recipient's bone marrow space, and it will start engrafting. Okay, this procedure of the stem cells will get used to the marrow space and they start proliferating there is called engraftment. So the supporting care that you have to give after the stem cell infusion is you have to give protective isolation, because now the patient's immune system is so much deficient of the immune cells to accept the stem cells. So the patient has high chance of getting infection. So preventing that, you have to give antibiotics and you have to protect and isolate the patient. And the blood component support also should be given because immune cells are not there, so still the patient requires immune cells. So you can give whole blood cells, platelet infusions you have to give for the patient to fight infection if it occurs. Okay, for 2 to 4 weeks you give blood component, and these blood component are irradiated because those cells that you are giving, that is, you give mainly packed cells and platelets. You don't give lymphocytes usually. Okay, so you give the packed RBCs. It should be deficient of the lymphocytes of the donor cells of the packed RBCs, because if the lymphocytes are present in the packed RBCs, that will cause graft versus host disease for the patient. So you irradiate the sample of platelet or the packed RBCs that you are giving to a patient of stem cell transplantation, and this irradiated blood component should be given for 2 to 4 weeks until the engraftment occurs. And you will tell engraftment is established when the peripheral neutrophil count. Okay, here it was total nucleated count. Here peripheral neutrophil count should be 500 per cubic millimeter on 3 successive days. Okay, then you call the engraftment a success. And if the engraftment is delayed, you can augment it with colony stimulating factors like GCSF and granulocyte monocyte. Now, coming to the complications of stem cell transplantation, infections are the main complication, that is especially in the neutropenic stage, that is still until the patient's neutrophil reaches a level of 500. There can be bacterial and fungal infections mainly. Bacterial also mainly encapsulated bacteria, that is pneumococcus, Haemophilus influenzae, etc. affects the post-splenectomy patients also, mainly those category of bacteria. And then when in the later stage of engraftment, you will get viral infections in the immunosuppressive stage, that is CMV, cytomegalovirus, herpes simplex virus, or varicella zoster virus. So to prevent these, you can give empirical antibiotics and antifungals. Now, organ toxicity. Organ toxicity is especially caused due to chemotherapy and total body radiation that is done for myeloablation. So, anti-cancer therapy is affecting the rapidly dividing cells because cancer cells are rapidly dividing. So, in our body, also the cells that are rapidly dividing are mainly liver, GIT, skin. They are constantly regenerating. Okay, because of their function. So respiratory epithelium, bladder epithelium, because you have that urination and then food eating, and skin also because it is constantly exposed to the environment. These keep on regenerating. So these epitheliums are very are the targets for organ toxicity. In liver, you will get veno-occlusive disease. When you get veno-occlusive disease, the patient will present with jaundice, hepatomegaly, right upper quadrant pain, ascites, and unexplained weight gain also. It is also called sinusoidal obstruction syndrome. And then hemorrhagic cystitis, if a patient is having, then he or she will present with hematuria, dysuria, urinary frequency, but the urine will be sterile. Okay. Pulmonary complications can be infectious or non-infectious. Seizure also can be affected if brain toxicity is there. Skin and mucosal changes that occur by conditioning are mainly alopecia, and then nail changes or oral mucositis. Now, other complications are graft failure. That is, the graft which is given has failed to engraft itself, or then there may be graft rejection also due to inadequate stem cells that are present in the stem cell transplantation. So in such cases as failure to engraft, you can give colony stimulating factors, and you can give additional growth factors, and you can infuse additional stem cells alone also, and then you can augment it with immunosuppression of the patient and more cytotoxic therapy so that the graft get engrafted. Okay. Other things are graft versus host disease also can occur, which is a complication. So the donor immune cells, they attack the recipient's tissues, and it can also affect organ toxicity, affecting skin, gut, and liver mainly. Okay. So the T lymphocytes of the donor cells, I said it can cause graft versus cancer effect affecting the rapidly dividing cells of the recipient, as well as it can affect the normal rapidly dividing cells, and it will cause graft versus host disease. So graft versus host disease can be acute or chronic. Acute graft versus host disease occurs within 100 days of post-transplantation, and chronic graft versus host disease affect later than 100 days. So acute may the affected targeted organ size of the graft versus host disease is the rapidly dividing cells, that is skin, gut, liver, etc., and it is associated with fever also if there is infection and all, or even if graft versus host disease can cause fever. Fever is especially caused not because of infection but because of the interleukin 6, 1, etc. So in acute, the severity can be graded according to the extent of the skin involvement, or if liver is affected, how much hyperbilirubinemia if the patient has, and gut according to the severity of the diarrhea. Okay, and then chronic, it clinically represents or resembles autoimmune disorders like scleroderma with skin rash, bronchiolitis, hepatic dysfunction, etc. And after a year or more, many patients develop self-tolerance, and these drugs can be used to taper off the graft versus host disease. Those drugs, that immunosuppressive drugs that can be used while graft versus host disease, is cyclosporin, prednisolone, and tacrolimus, etc. By the time engraftment occurs, maybe the graft versus host disease also will get resolved. So, and it is more common in older patients and those when there is unmatched HLA transplants. Now we come to tumor relapse. So tumor relapse is also a complication. While a certain number of patients may have relapse of the original malignancy even after stem cell transplantation, as the tumor cells survive the chemo, radiotherapy, and the graft versus cancer effect also. So in such relapse conditions, relapses are higher if stem cell transplantation is performed when disease is not in remission, especially, or in aggressive stages or in advanced stages. Okay, so we are giving radiation to destroy all the cells, but still it is not under remission. The disease is not under remission. There is high chance of tumor relapse even with stem cell transplantation if graft versus tumor effect is also crossed by the disease cells. So these are usually treated by infusing lymphocytes, that is donor lymphocyte infusion, okay, from the original stem cell donor. The stem cell donor who has given the stem cells, from that donor itself, you are taking lymphocytes to destroy the present tumor cells or the residual disease in the patient or relapsed patients. You will give donor lymphocyte infusion. Now, disease-specific recommendations are in acute leukemia, AML में in high-risk cytogenetic cases, allogeneic stem cell transplantation is recommended, especially when there is first remission. In ALL, it is beneficial mainly in high-risk diseases and in second remission. Okay, when you are giving chemo and radiotherapy, if it is not becoming effective, then you can go for allogeneic stem cell transplantation, or if there is already high risk diseases, you can start on with stem cell transplantation also. It is dependent on the patient profile and the doctor's perspective also, like to choose for chemo, radiotherapy, or the stem cell transplantation. These are the recommendations. In CML, it is reserved mainly for tyrosine kinase inhibitor failure, because after the invention of the tyrosine kinase inhibitors like nalotinib, imatinib, etc. So those are the main stage therapy. But if the patient is still intolerant to these therapy, then you have to go for stem cell transplantation. In CLL, you will resort to stem cell transplantation only when there is high risk disease and when there is early relapse of the CLL. And especially they are older disease patients. So older patients may stem cell transplantation has organ toxicity or because of conditioning, and there are many other things also to consider. Non-malignant disorders in that aplastic anemia, first line treatment is allogeneic stem cell transplantation, especially if it is young patients and you get a matched sibling. Okay. And in thalassemia major also, best results is got when it is performed early in the disease, even before the iron overload or transfusion related complications are becoming prominent. Before that itself, you start giving allogeneic stem cell transplantation, then the patient have to not undergo like continuous blood cell transfusion. You know, in practice, when thalassemia patients come, they need continuous blood cell transfusion because hemoglobin is less. So the more blood cell infuse packed RBCs and all you infuse, the more donor lymphocytes are coming into the patient's body. And that also different type of donors will be coming because they are requiring like more blood cell transfusions. So because of that, more different type of immunological lymphocytes will be in the patient's blood, and that can cause graft rejection also. So even before the blood cell transfusion, as early as the disease thalassemia, if you're giving stem cell transplantation, success is very good. In other diseases like in lymphoma also, autologous stem cell transplantation is recommended in case if there is relapse or treatment failure. And in myelodysplastic patients, it is the only curable treatment, allogeneic stem cell transplantations. But the problem is, as the patients suffering from MDS are often elderly, the transplant is toxic and because of the conditioning regimen and all. So you have to weigh the benefits and risks in such cases. So in Indian experience, first bone marrow transplantation in India was done in 1983 and it was performed at Tata Memorial Hospital in Mumbai. In 1986, the first allogenic bone marrow transplantation was done in CMC Vellore. This was a autologous bone marrow transplantation. This was allogenic. And for aplastic anemia using peripheral blood stem cells in Indian centers, survival rate is 70 to 80%, which is really good. Indian centers have shown that allogenic transplantation is now safely being performed in non-HEPA filtered rooms also. A number of transplants in India is expected to increase sharply in the coming years. So take home message is that allogenic stem cell transplantation should be offered to patients where the benefits outweigh the risks. Okay. And non-transplant therapy should be compared to the stem cell transplantation before making any recommendations. In disease where non-transplant is better, you can go for that option. But if both are same, you have to check in early disease stages. If stem cell transplantation is better, then you have to go for that. But you have to keep in mind that there is conditioning related organ toxicity, etc., for the patient also, and how much the patient can afford also. So, counseling of the patient and patient preference is extremely important as stem cell transplantation involves considerable expense. Often prolonged morbidity and even fatality also can happen because graft versus host disease is also dangerous. Okay. So the patient also should know the risk, patient family also should know the risk, and the clinician also should take a reasonable decision. So I thank respected Rajat Kumar sir for contributing this very beautiful article in recent advances hematology 3. Kindly do like, share and subscribe this channel and comment your doubts or if you have any topics in mind to be presented by me. So thank you. Have a nice day.